first thing we're going to cover is how to motion palpate the hip joint. So the subluxations that we are looking for are an internally rotated proximal femur and an externally rotated proximal femur. Those are our two possibilities. So what we want to do is kind of run the hip joint through both of those motions to look for any restriction or a block in internal rotation or external rotation. So you can either do this prone or supine. To do it prone, you can bend the person's leg up to 90 and then you can try and go into external rotation, just looking for any blockage or resistance. And then you can also go into internal rotation. So you're going to note which one feels harder compared to the other, and that can be one of your indicators for subluxation. The other thing you can do is you can palpate the greater trochanter. So once you find that, you can palpate the posterior aspect of it and also the anterior aspect of it to see if there's tenderness on either side. The posterior tenderness is going to go with an externally rotated subluxation, and the anterior tenderness is going to go with an internally rotated subluxation. So in the supine position, you can also do motion palpation of the hip. So what you're going to do is bring the hip and the knee up to 90. Then you're just going to run the hip through external rotation and internal rotation, and you're going to look for any restriction in either of those. So if the hip struggles to go into external rotation, it's likely that we have an internally rotated hip joint. If the hip struggles to go into internal rotation, it could be that it is stuck in external rotation. So if we think that the hip is subluxated, what we can do is do a muscle test in order to confirm that, and that would be testing the TFL. And so what you're going to do is get the person to raise their leg and hold it up here. You're going to hold just proximal to the ankle joint, and you're going to push in a direction that way, where you push in extension as though you're going to push the leg into extension and adduction. So you're going to kind of push downwards, and they're going to resist you. And if it's weak, that means that the person probably has a subluxation of the hip on that side. So in order to adjust an internally rotated proximal femur, the contact point on the patient is going to be the anterior aspect of the greater trochanter. You are going to use your pisiform. The person's going to be laying supine. Your line of drive is going to be basically S to I straight down the table, because we're going to try and push the hip into external rotation because it's stuck in internal rotation. For this specific listing, so the internally rotated hip, you're going to have tenderness on the anterior aspect of the greater trochanter. And the stabilization hand is going to kind of weave through the legs in the way that I show you right now. So you want to stand on side of your contact point, and you're going to get the person to lift their leg, their hip at 90 and their knee at 90. So my contact hand is going to be this hand. My pisiform is going to need to contact down on the anterior part of the greater trochanter. So I might just move your arms a little bit. That's good. So my other hand is going to need to provide the pretension, and the pretension is going to be to put the hip into external rotation. So we want to push the hip further into external rotation than it is, because obviously it's stuck in internal rotation. So the way that we do this is we use our stabilization arm, and you're going to wrap the inside of the knee and then pop the dorsum of your hand on the outside of their lower leg, and you're going to push the, yep, that's it, push the hip into external rotation. So we're trying to prime it in the direction that we want it to go. So you're going to use your pisiform. You're going to need to get really low in this kind of lunge position. You're going to contact the anterior part of the greater trochanter. You want to kind of make sure that your line of drive is purely S to I. I guess it's a little bit A to P as well, but mainly S to I. So you've pre-tensioned your pisiforms on the anterior part of the greater greater trochanter, and then you're going to thrust in an S to I direction down the table. So the other way that you can adjust an internally rotated hip, if the person's slightly bigger than you and it's an effort to do it in the manual move like I just showed, you can do it on a drop table if you have a drop table available. So what you can do for this one is just put them into that Faber's position that we've done before, if they have the flexibility to do that. Then you're going to again contact the anterior greater trochanter. You can use the heel of your hand to kind of anchor in on that contact. You can just stabilize on the opposite side, ASAS. You just need to watch where you are relative to their knee as well, mainly for guys. And then again, with using a drop table that just drops straight down, you're just going to drop through in an A to P direction in order to correct internal rotation of the hip. So if we move on to the externally rotated femur, so the motion would have all been the same, but you would have had restriction going into internal rotation, because it's stuck in external rotation. You'll also have tenderness on the posterior aspect of the greater trochanter. You'll also have your positive TFL test, because that goes with both of these listings. So the way that we want to set this up is, again, the person's going to be supine, but now we're going to be contacting the posterior aspect of the greater trochanter. So it's similar in kind of patient position again. They're going to be with their hip and their knee at 90. We're going to, again, kind of weave through the leg like this. So you've gone on the inside of their knee, and now you have, instead of down at their feet, you're going to have the dorsum of your hand on the outside of their lower thigh. So you're going to, because we're wanting to push the femur into internal rotation, because it's been stuck in external rotation, we want to, again, kind of twist the leg in order to put it in that internally rotated position. So that's what our pre-tension is going to be. The doctor's contact point is going to be the heel of the hand on the posterior aspect of the greater trochanter. So again, putting the person into this internally rotated position, getting quite low because we just want our line of drive to be straight up the table or I to S, anchoring into the posterior aspect of the greater trochanter, and then the adjustment and the thrust is going to be in that direction. You can also do this on the drop table if you flip over onto your tummy. So this time you don't need to put the person into that for bear type position like we did for the internal rotated. You can just literally place them appropriately on the table, which you guys know how to do. You can contact the posterior aspect of the greater trochanter. Again, you can use the heel of your hand as a contact, and you're just basically going to thrust P to A in order to correct that external rotation. The other way that we can also do this, if the first one, obviously the first one I showed you, it's rather hard to do if the person's bigger than you or their leg is really heavy. So there's another way that you can manually adjust the hip as well. So that way is taking a seat on the table next to them and resting their leg on your shoulder. So what you're going to do is we're going to use a lot of pre-tension here in order to help us get the right correction. So if we have an externally rotated hip, in order to correct this in this position, is that we can take a tissue pull into internal rotation, apply a little bit of traction, and then thrust S to I down the table. And that's another way that will correct these listings. So if we're externally rotated, we want to wrap our hands around and take out that external rotation. So you're kind of going this way with your tissue pull. You stabilize with the opposite hand, you traction a little bit towards you, and then your thrust is just going to be straight S to I down the table. So obviously with an internal, when you need to go like this and tissue pull from internal into external rotation, you need to kind of be careful about where you are touching and how you're communicating with your person, because you don't really want to just be like fishing around in this area in order to make sure that you're just on the femur. So you can kind of visualize where you are, feel where the femur is, take the tissue pull from internal to external this time. Same thing, you're just going to traction down, and then your line of drive is just going to be straight S to I down the table. If we move on to motion palpation of the knee now, what we want to motion palpate is the tibia, the fibula, and also the patella. So each of those has its own motion palpation category. So if we start with the tibia, there's two ways that we can look for subluxation in the tibia with motion palpation. In the first one, you get the person's knee up at 90, and you kind of rest the lower part of their leg on your knee on the table. So what you're going to want to do is palpate along the tibial plateaus. So you're going to want to find the joint line, palpate just down, and obviously we'll do this in lab so that you guys know all the bony landmarks. And then we want to run the lower leg through internal and external rotation. So if we push the foot and the lower leg into internal rotation, we expect underneath my thumb, or the anterior lateral part of the tibia, is going to butt into my fingers, because the tibia is going like this into internal rotation. So we've found the joint line, we're on the tibial plateaus, and we're going into internal rotation. we expect the tibia to bump into my thumb. When we go the opposite direction, we go into external rotation, we expect the anterior medial plateau to butt into my fingers. So if you are doing external rotation and you don't feel the anterior medial plateau bump into your fingers, it may mean that the tibia is stuck in internal rotation, or what we call an anterior lateral tibia. Same goes in the other direction. So if you're doing external rotation and it's bumping into your fingers nicely, but you do internal rotation and you don't feel the anterior lateral tibial plateau bump into your thumb, that may mean that it's stuck in external rotation, or that we have an anterior medial tibia. This one can take a little bit to get your head around, and it's definitely one that we're going to go over in lab. But it's good that you guys will have this at least to start getting your head around it, so that when we're in lab it'll be a little bit more streamlined, which is good. So one note that I do want to say about this is that you're going to have a lot more external rotation of the tibia than you are going to have internal rotation. It's usually a ratio of like 2 to 1. So you're always going to feel like an external rotation, there's more movement or more motion. So just bear that in mind when you are coming up with the listing. The best thing that you can do is compare it to the opposite knee and look for restrictions side to side, rather than being like, yeah, this definitely moves a lot more in external rotation than it does internal rotation, because that's actually kind of what we expect. The next thing that you can do for motioning the tibia is to look for anteriority or posteriority, and that's just how you guys have done your anterior and posterior draw test. So the same thing, you basically just sit on the person's foot and you're going to try and draw the tibia forward in a P to A direction, and then push the tibia back in an A to P direction. So if you're pulling forward and there's restriction, it may be a posterior tibia. And if you're pushing forward and trying to go A to P and there's restriction, you may have an anterior aspect to your listing of the tibia. So our 3 listings that we have as possible is an anterior lateral, or what's kind of stuck in internal rotation. We also have an anterior medial, which is stuck in external rotation, and then we just have a straight posterior tibia, which can come when there's trauma to the front of the knee. The next thing we want to look at is the fibula. So there's a number of ways to motion the fibula. The first one you can do just P to A and A to P sharing. This one you need to be really careful because it's usually super tender up here. You've got the peroneal nerve that wraps in and around the back here, so you don't want to be putting too much pressure through here. But you can use a kind of soft pincer grip and just do small movements in order to gauge whether the fibula head is moving forward or back. The listings for your proximal fibula are going to be an anterior lateral or a posterior medial. So it kind of comes forward and out, and then if it goes back, it will go back and in. So you can kind of use your pincer grip to put both those vectors together and kind of try and pull out, forward and out, and then try and push in and back, if that makes sense. So that's your first one for your fibula. The other possibilities for listings for the fibula that it can go superior or it can go inferior. And the way that we can look for this is with dorsiflexion and plantarflexion of the foot. So again, you can kind of do this in whatever position you want, but this works well. If you pop your fingers on the proximal fibula head, and then you run the foot into dorsiflexion, you should note that the fibula head will move superior. And then when you move into plantarflexion and inversion, you should note that the fibula should all move inferiorly. So the first one, sorry, is dorsiflexion eversion, and then if you go the opposite and you go plantarflexion inversion, you should notice that the fibula will move up and then drop down. So that's the next one for that. The other possibility is the patella. So the patella is kind of like the scapula, where it kind of just floats in space there. And so all you're going to really do is push the patella around. So you can go left to right, up and down. You can kind of see if there's a combination of vectors where it's subluxated. Most commonly it'll kind of go superior and lateral. So you may want to push in an angled direction as well, just to get a sense of whether it is stuck in that direction. But yeah, you basically just push it around, look for any restriction. Again, it's going to not move into the position where it needs to go. So if it's stuck in a lateral position, it'll move really nicely laterally, and it won't move nicely medially. So kind of like the scapula in that regard, which we have done.